Thank you. Thank you. Good morning, everyone. So, my topic is hyperactive sexual desire disorder, addressing an unmet medical need. Female sexual dysfunction, it is a highly prevalent, often underestimated problem in the general community. It is a multifactorial, age-related, and progressive problem. If we go by epidemiology, there are only a few epidemiological studies on the prevalence of the sexual disorder from India. The prevailing cultural beliefs and stigma in India might discourage and inhibit the individuals to consult a doctor and discuss their sexual life, which makes it difficult to know the extent of the problem. The prevalence of the female sexual disorder was found to be around 14% in a study from South India. Based on the analysis of a few population studies, the prevalence estimated for female HSDD was shown to in range from 5 to 46%. Female orgasmic disorder from 4 to 20%, and dyspareunia was approximately 8%. The current scenario in India is not bright, with a majority of sexual dysfunction patients being handled by local quacks, faith healers, and other non-professional individuals who project themselves as an expert. Poor knowledge of the problem, lack of adequate health facility, lack of adequate number of professionals in the field, and cultural influences have a negative impact on management of sexual dysfunction. Gynecologists have to play an important role in prevention, detection, as well as management of the sexual health, as we are the first whom women approach and have a trust to share their issue. Gynecologists should understand the basic sexual medicine and ask their patient regarding their sexual problems and sexual health. It is a study from the South Indian rural population where around 14% of the female subjects were diagnosed to have a female sexual disorder. Prevalence of the female arousal dysfunction was found to be 6.65%. Female HSDD was around 8.87%. Female anorexia was 5 to 67%. Female dyspareunia was 2.32%, and female sexual aversion disorder was found to be prevalent 0.37% of the female subjects. So, if we divide the sexual disorder, it can be either a desire disorder, arousal disorder, orgasmic disorder, and pain disorder. Sexual desire disorder is either of the hypoactive sexual desire disorder or sexual aversion disorder. But today's topic is hypoactive sexual desire disorder, in short, HSD. Hypoactive sexual desire disorder is the most prevalent female sexual health problem, and HSD may be primary or secondary, lifelong or acquired, or generalized or situational. If you define the HSDD, it is a persistent or recurrent absence of the deficiency of sexual desire or receptivity to sexual activity that cause marked distress and interpersonal difficulty. For a diagnosis of HSDD, the desire problem must not be better accounted for by any other psychiatric disorder such as depression, substance abuse, or medical condition. Psychopharmacology of sexual motivation and desire. A large aggregate of animal and human literature on the psychopharmacology of the sexual motivation and desire report that sexual desire can be inhibited by drug or condition that decrease the brain dopamine level, augment the action of brain serotonin specifically through the serotonin 2A receptor, or increase in upward acting at mu receptors. Conversely, sexual desire can be stimulated by drug or condition that increase the hypothalamic and mesomebilic dopamine, or decrease in the serotonin release, or inhibit postsynaptic binding in the prefrontal cortex. So, to diagnose HSDD, it begins with a thorough history to determine whether the root cause is neurobiological, interpersonal, psychosocial, or some combination of these. It may include bothersome or distressing symptoms of reduced motivation for particular participation in sexual activity. Symptoms of the HSDD may also include distressing behavioral manifestation of motivation, such as the reduced or absent initiation of the sexual activity, evidence of the situation that could lead to sexual activity, like going to bed after partner is asleep, restricting casual physical contact so as not to lead the partner to misperceive the interest in sex, participation in sexual activity only out of obligation or due to fear of loss of partner. Relationship issue. Relationship issue may lead to low desire but should be addressed and excluded as the primary etiology before diagnosing the generalized acquired HSDD. The diagnosis of HSDD does not require complete loss of sexual desire, but rather a change for at least 3 months from what it was previously. Importantly, personal distress is a prerequisite for the diagnosis of HSDD. The distress may manifest as a frustration, grief, incompetence, loss, sadness, sorrow, low self-esteem, confusion, and worry. But this should not be the cause of the diminished desire. How to screen the decreased sexual desire? A 5-question instrument completed by the patient was developed and validated for the use of by clinician to aid in the making the diagnosis of HSDD. Women indicate yes or no response to these 5 questions. The purpose of question 1 to 4 was to determine whether there is an HSDD. If the patient responds yes to all the questions, this is consistent with the generalized acquired HSDD. And the purpose of question 5 is to help to determine whether the etiology of HSDD is primary or secondary. These are the 5 questions. First is in the past, was your level of sexual desire or interest good or satisfying to you? Second question is has there been a decrease in your level of sexual desire or interest? Third question is how are you bothered by your decreased level of sexual desire or interest? Fourth question is would you like to level of your sexual desire or interest to increase? So these are the 4 main questions to decide about the HSDD. And the fifth question is to rule a cause of the HSDD. This in the fifth question there are sub questions like an operation, depression, injuries, or other medical condition, medication, drugs, or alcohol you are currently taking, pregnancy, recent childbirth, menopausal symptoms. Question number 4 is D is the other sexual issue you may be having. Question number E is your partner's sexual problems. And question F, dissatisfaction with your relationships or partner. And question G is stress or fatigue. All questions they have to answer in yes or no. If the patient answers no to any of the questions from 1 to 4, then she does not qualify for the diagnosis of HSDD. If the patient answers yes to all the questions of 1 to 4 and your review confirms no answer to all of these factors in the question 5, then she does qualify for the diagnosis of generalized acquired HSDD. If the patient answered yes to all the question 1 to 4 and yes to any of the factors in question 5, then decide whether the woman answer to question 5 indicates a primary diagnosis other than generalized acquired HSDD. Comorbid conditions such as arousal or organic disorder do not rule out a concurrent diagnosis of HSDD. So this is a very important screener for the HSDD. Physiology of the management. Now a patient-centered approach should be followed in every sphere of medicine. Nowhere is this truer than in sexual dysfunction. While individuals suffering from FSD share many factors, some factors such as the psychological and environmental factors could be unique to individual patients. Hence, the management plan need to be individualized. Patient-centered care has been defined as a care that is respectful of and responsive to individual patients' preference, needs, and values, and that ensures that patient value guide all clinical decisions. Patient-centered care in the context of FSD implies understanding the patient's background, her attitude, beliefs, knowledge, and misconception about sexuality, fertility, and related issues. Not only that, PCC mandate an appreciation of the physical environment of the patient, such as privacy and comfort available to her and her partner. It also requires an in-depth analysis of the biological status of the patient with FSD, like her medical, endocrine, and urogynecological health. Now, a patient-centered approach should be followed in every The concept of PCC in FSD, however, goes beyond the individual. Sexual function is not possible without a partner. Therefore, FSD counseling and management require the use of a couple-centered approach. So now we come to treatment part. Sequence treatment that focuses on the suspected primary contributing component or components, emphasizing the treatment of the factors that are most distressing to that individual woman. Brief office-based counseling may be helpful using PLI SSIT model, that is permission, limited information, specific suggestions, and intensive therapy. A step approach specifically for general healthcare provider caring for women with sexual concern. If psychotherapy is indicated, the patient should be referred to sex therapist for management, including determination of the appropriate form of therapy for that patient and couple. Cognitive and motivational aspect. Psychotherapy is a recognized treatment strategy for HSDD, typically focused on modifying thoughts, beliefs, behaviors, emotions, and relationships communication behavior that interfere with the desire. Sunset focus. Sunset focus therapy involves a graded series of non-demand sensual touching exercise. Typically used with couple, the objective of sunset focus therapy are to reduce anxiety and avoidance of sexual touching or sexual activity, improve sexual communication between partners, and improve intimacy by reintroducing sexual activity in a gradual way. Cognitive behavioral therapy. It focuses on the altering thoughts and behavior that distracts or result in inhibiting sexual thought in a sexual situation with specific focus on automatic thoughts and beliefs that may inhibit sexual desire. Therapy serves to change the sexual behavior by focusing on pleasure and not on sexual form and planned sexual activity and sex exploration instead of avoidance of sexual activity. Mindfulness. The goal of mindfulness-based cognitive therapy is to encourage participants to connect and engage with their sexuality by learning and participating a variety of mindfulness exercise that attempt to improve awareness of the here and now and acceptance and self-compassion. Therapy also includes an educational component regarding female sexuality and sexual function. Now we come to the neuroendocrine or neurochemical aspect, which is known libanserin, which is marketed as a female Viagra. Originally developed as an antidepressant with a potentially rapid onset of action, libanserin was approved by the Food and Drug Administration for HSDD in August 2015. Libanserin dose at 100 mg at bedtime is a non-hormonal centrally acting polysomniatic serotonin 1A receptor agonist and serotonin 2A receptor antagonist that result in the decrease in serotonin activity and increase in dopamine and norepinephrine activity. Administration during working hours increase the risk of hypotension, syncope, accidental injury, and depression. Is discontinued after 8 weeks if no improvement occurs. In case of missed dose, the patient should take the next dose at bedtime the next day. Dose should not be doubled. Currently, it is not indicated in postmenopausal women, neither is it indicated to enhance the sexual performance. Contraindication for libanserin are alcohol use and hepatic impairment. Adverse reaction, libanserin may cause CNS depression with somnolence and sedation. Fatigue, insomnia, and dry mouth can also occur. Patients should not drive or engage in other activity requiring full alertness until at least 6 hours after taking libanserin. Concomitant use of the CNS depressant may increase side effects. Libanserin by itself can cause hypotension and syncope. Now we come to testosterone. Testosterone therapy is an evidence-based off-label treatment for perimenopausal and postmenopausal women with SSTD. Transdermal testosterone therapy using 13 microgram dermal patch has been consistently reported in multiple studies to be effective for the treatment of HSDD. And various studies have also confirmed the use of testosterone beneficial in the various sexual dysfunctions. Now, buspirone. Buspirone is a serotonin 1A partial agonist. It's approved as an anxiolytic for the management of generalized anxiety disorder and the short-term relief symptoms of anxiety. And it is also used as a off-label treatment of HSDD. So now, in conclusion, hypoactive sexual desire disorder in women is an important female sexual dysfunction that has been well characterized for more than 3 decades. Be aware that diagnostic assessment of the woman with HSDD engage a biopsychosocial perspective and is primarily based on history. The decreased sexual desire screener is a validated instrument that aids in the HSDD diagnosis. The treatment of HSDD may also engage both psychosocial and biological strategies. Treatment should focus on the factors that are most distressing to the individual. In conclusion, HSDD is a highly prevalent but often undiagnosed condition that can effectively be managed by the specialist with appropriate assessment and individualized treatment. Thank you. Thank you for your patient hearing.